Okay, thank you. Sorry for inconvenience because there was some problem in the screen sharing. I'm very thankful to Society of Yemeni Neurosurgeon and PSN that who gave a chance to have a talk on such a very critical topic. Just we will discuss the anatomy of brainstem, some deviance, and a little bit a brief introduction of safe intizomes in the corridors to the brainstem. There is a saying that size not, but capabilities matters. That we can see a huge and big stone that is being uh, uh, thrown by a very small child. It's very true regarding the brain stem when we see the brain as a whole. The brain stem is just about 2 to 3% of the whole brain, and it's about 25 centimeter cube of whole volume. So it's being that we can see that it's so tiny and so small, but it is so capable that is controlling a lot of functions. And on the brain stem, a lot of I can say that the whole life is dependent on the brainstem. That's why then when the death is being declared, uh, often and very soon and early we see the brainstem reflexes. We can see in the picture that it's so small when we see the whole volume of the brain, but this small area, it is doing a lot of work. So these are some general features. It is about only 2 to 3% of the total brain volume. It's just a 7.5 centimeter total length. You can say that it is about only a index finger length of the whole brain, 7.5 centimeter. Occupies the posterior fossa. It has the good work that it connects the cerebral. Important that it serves as some passage between the cerebral cortex and spinal cord for the very important ascending and descending tracts. It contains some very important reflex centers to control our very important two systems, that is the cardiac and respiratory. And out of 12, the 10th cranial nerve nuclei, they are also present in the brainstem to regulate different functions. So the brainstem is being divided into three main parts. We can see here the lower one, it is the medulla oblongata and the pons and midbrain. It has the connection lower part with the spinal cord, and the upper part, the midbrain, is through the cortex or the forebrain for regulating different functions. Step by step, we will discuss the gross and detailed anatomy at each and every part. When we see the medulla oblongata, that is the lower part, from the cerebrovertebral junction is there, and the foramen magnum. It starts from there and it ends at the pontomedullary junction. That is the area. And below it is continuous with the spinal cord, and above it has the connection with the pons. And when we see, there are two main surfaces of the medulla oblongata. One is the anterior surface, or we call it the ventral one, and second is the dorsal face surface. We can say the superior aspect of the medulla oblongata. This picture shows the ventral aspect of the or anterior aspect of the medulla oblongata, and we can see in the anterior aspect a very midline structure or fissure or sulcus, we can say, that is called the anterior median sulcus or fissure. That is continuous downward below with the spinal cord as such as the anterior spinal sulcus, we call it. Same like that. On with this sulcus is very important. Surgical point of view, we will later discuss that how this sulcus helps us to enter into the medulla oblongata. So on either side of this sulcus is two elevations that is called the pyramids. These pyramids down goingward at the just above to the spinal cord or the below side of the medulla oblongata, the decussate. This pyramid is nothing, just is that these are the corticospinal fibers that come from the forebrain or the cortex. They come here and then decussate and contralaterally the down goward. On the either side, on the anterolaterally to these pyramids, another elevation is there that is called olive. Olive. That's because of the olivary nucleus is there. In between these two, this the pyramid and the olive, we can see a sulcus here. That is the
Dr.
medulla-olivary.
Etizaz,
We are talking about the ventral surface of the medulla oblongata. Just lateral to this pyramid, there is a sulcus. That is the ponto-olivary sulcus. On the lateral side, this is the second elevation. This is the second one above. Uh, in between these two, this sulcus, it is very important because the hypoglossal nerve that originates from this sulcus, and from lateral to this one, just lateral and the posterior to olive, there is a middle cerebral peduncle that has been dissected. Oh, sorry, inferior cerebellar peduncle. Between this olive and inferior cerebral peduncle, three remaining nerves, because the medulla oblongata, it originates the four lower cranial nerves, the ninth glossopharyngeal vagus nerve and the cranial part of the accessory nerve. So this is the ventral surface of the medulla oblongata. And above one, when we see the pons in between these two, is the ponto medullary sulcus. It is very important regarding some structures of the that originate from the bones. When we see the dorsal surface, you can say the posterior surface or the medulla oblongata, the superior part of the posterior surface of the medulla oblongata, it forms actually the floor of the fourth ventricle. That is very important. This is the floor of the fourth ventricle. The lower part is formed by the superior half of the medulla oblongata, and superior part of the floor of the fourth ventricle is formed the lower half of the, you can say, the posterior surface of the pons. So when we see this the conical structure in this one, again there's a midline fissure that we call it the posterior median sulcus. uh, this same sulcus continues below with the spinal cord as the posterior median sulcus of the spinal cord. We can say that's why we can say as the spinal cord is the continuation of the medulla oblongata. So little bit is some a mirror image of the medulla oblongata. On either side of these two, this one, the median sulcus, posterior median sulcus, again there's elevation and the bulging is there. That is called the tuber gracilis. And on the lateral of this one, tubercle gracilis, there is again one. There is a tubercle cuneate. In between these two, these are the sulcus. Underlying these structures, in underlying of the tubercle cuneate and the gracilis, there is the nucleus gracilis and the nucleus tubercle cuneate. That goes for the tracts to the posterior column of the spinal cord. So when we see above structures in the floor of the fourth ventricle, it gives some triangle. Uh, in the below one, we can see this is the hypoglossal triangle, and above and the below one, this is the vagal triangle, and then superior on the either side. These are the above to the triangle, above to the vagal triangle. These both side on either side bilaterally. These are the vestibule triangle. These are the structures. It's the same. The cadaveric view of the posterior surface or the dorsal surface of medulla oblongata. It shows some same structures. So after the medulla oblongata, when we see the pons is the some anterior and same surface of the posterolateral. The pons is on the either side and anteriorly on the ventrally. It is some convex area, the huge convex area. This anterior surface is whole. It is traversed by the transverse fibers, the pons on the anterior side, and these transverse fibers on the lateral side, anterolateral side, we can see the bulging. This bulging is there. These transverse fibers converge on the both lateral side, and they form again a second connection with the cerebellum that we call it middle cerebellar peduncle. So middle cerebral peduncle, nothing is just because the connection and some tracts which goes to from the pons to the cerebellum for different functions in the motor functions. So on the lower side of this one, that is the pontomedullary sulcus is there. That is very important sulcus. On this one, this is the foramen that is called the foramen cecum. Just above the foramen cecum in the midline, this is the groove, and that groove is for the basilar artery, the very important structure. On above side, that in goes to the midbrain. We will see later on the midbrain that where it resides. This pontomedullary sulcus, we call it. It is again an important structure because the four cranial nerves, three cranial nerves, they arise from here. From medial to lateral, we can see this is the abducent nerve, and then seventh eighth complex, 7 and 6 complex. This one abducent, and then laterally seventh eighth complex. On the middle side of the bones, on the anterolaterally, we can see the fifth nerve originate from here. It has two parts. One is the motor and sensory. The small one, which shows here, it's the motor, and the large one, the pons. Above, on the upper side, the pons is connected with the midbrain, with the sulcus between the pons and the midbrain. This is the dorsal surface, or we can say the superior surface of again, the pons. It forms the superior part of the fourth ventricle floor. Uh, Again, it has some median sulcus is there on either side of this median sulcus. There are some elevations that is called the medial eminence. This is called the medial eminence. These both these both on the medial elements, and the both side on the lower side of the area that we called, and again that is the bluish area that is called the substantia nigra. And so this is the midbrain. And midbrain, again, it has some ventral surface. It is the ventral surface of the midbrain. We can appreciate some very important structures when we see the gross anatomy of the midbrain. This is the crus cerebri of the midbrain, and this is the sulcus in between the midbrain and the pons. Above to this one, this is the fossa, that the depression. That is very important fossa. Later on, we can see the structures inside it. That is the interpeduncular fossa. It has some important structures, and intraoperatively we can see that what is the landmark of this one. And superiorly, one can see the here on the above side, this is the tuber cinerarium, and in the below this one, lower side, these are the mammillary bodies. These two. Midbrain, or hold the brain stem. At the lower side, it has the extension till the spinal cord, and the superior side, it has the extension till the optic apparatus. We can appreciate the optic chiasm as well here. Till the optic chiasm, it is the area of the brain stem, and especially the midbrain. This is the same picture. This is the tuber cinerarium. These are the mammillary bodies. I will go into the dorsal surface of this one. This is the dorsal surface of midbrain. That is very important and contains very important structures. So superiorly, we can see here the third ventricle, and we can see the four bulgings on the lateral side, two above and two below. The superior two, these are the superior colliculus, and below one, these are the inferior colliculus, and this is the pineal gland. So these superior colliculus, when we see laterally, this has some bandage-like structure that is called the brachium. And this brachium, they connects the superior collex to the lateral geniculate body. This is the lateral geniculate body laterally, uh, for the visual apparatus, optic radiations. And this inferior colliculus, again, this has the brachium. This is the bandage-like structure, fibrous structure that connect with the medial geniculate body for the auditory areas. Below this one, we can see this on the lateral surface. These two thread-like structures are going. This is actually the fourth nerve that is called the trochlear nerve. So this is the only nerve, trochlear nerve in the brainstem that originate or arise from the dorsal surface. Most of the all nerves, they originate and rise from the anterior or anterolateral surface, but has the origin from the dorsal surface of the midbrain. This is the same picture. So this is the endoscopic view, and we can appreciate the midbrain interior anatomy and the floor. We can see the pineal, the pituitary bilateral, superior colliculus, inferior colliculus, and this is the fourth nerve, the trochlear nerve. We can appreciate. So this is the brief introduction of the anatomy of brainstem little bit. When we talk about the surgical safe corridors, to me, I divide the surgical corridors into three main surgical corridors. One, when we say that the surgical entry zones in the brainstem, when we are entering in the brainstem, what is the surgical corridors could be? And second, when the surgical corridors to the brainstem, when we are approaching the brainstem, like the pathologies that is not intrinsic or not the diffuse infiltrating just at the brainstem, what could be? And second, the approaches, the safe approaches that can lead to the corridors. Most of the time, the brainstem most likely it has the gliomas, that is the infiltrating type. Most of the gliomas, they are infiltrating, that as the diffuse type, that is the very go inside to the parenchyma. And second, the cavernomas are there. So when we go inside to the brainstem, enter to the brainstem, there is a very safe zones. It has shown here that it is denoted, and the literature says that we choose the sulcus area, sulcus of this one, not on either side. When we see the medulla oblongata, we know that there are two sulcus. One is the anterior one, that is the anterior median fissure, and one is the posterior one, that is called the posterior median fissure. And second is the when we see at the level of olive and the medulla, olive and the pons pyramid, that sulcus can be chosen to get entrance into the medulla oblongata. Otherwise, this is very dangerous to go inside into the medulla oblongata. Any side of the brainstem, we can say, like it could be the pons, it could be the uh, midbrain. Same likewise, the pons, we can see the median fissure, and some again there are different structures there. Like we can go on the above just lateral side of this one, that is called the medial eminence. On the medial eminence, just laterally we can go inside, and the median fissure of the pons and laterally. This is the midbrain. Midbrain has some different and a lot of approaches to enter in it, and some pathologies can be added to the midbrain. When we see here, this is the lateral sulcus, the medial sulcus of the crus cerebri. This could be the entry zone, the safe entry zone in between these to the medial side of both crus cerebri. And second, we can go endoscopically when we are going into the third ventricle. And second, superior colliculus and inferior colliculus. Below to the superior colliculus, inferior to the colliculus, it is shown that we can go to the we can approach the midbrain as well. Endoscopically, when we are going, I told that interpeduncular fossa, which is very important clinically and as a surgical corridor, um, because it contains some important structures like the third cranial nerve is there, like the basilar artery is there. When we are going endoscopically, to either we are doing the ETV or getting any biopsy. That's why when it's being going a little bit posterior, we can enter into the interpeduncular fossa, and that can damage the oculomotor nerve and the basilar artery. This is some diagrammatic and pictorial expression of the different approaches and safe entry zones, anterior mesencephalog, what we call it, what I call it, the medial to the crus cerebri, and this is the median fissure. This is laterally the Oliveira zone that is in between these two, because it is devoid of some functional tissues, or you can say the nuclei of the cranial nerves. That's why we can enter into it. This is another pictorial and diaphragmatic expression of this one that shows this is the upper side. This shows the midbrain approaches. That above through this one is the superior colliculus approach. That number one, it shows the medial part of the crus cerebri, this sulcus, the medius sulcus. This one number showing it is the median sulcus of medial sulcus of the crus cerebri. Number two, it shows the superior colliculus, and number three, it shows the below to the inferior colliculus, just above the fourth nerve. And these are the approaches to the midbrain, the median sulcus. On either side of the medial eminence, that is called the sulcus limitans, and the vestibular area. And the below urban, the medulla oblongata, it has a large sulcus area, so we can go and enter into this one. To enter into the brainstem, but it's very critical to get anything from the brainstem, because it is very some crucial structures and very important structures are there. So just we can take the biopsy. And second, when we talk about some approaches, so we know very well that how to go there. It could be the posterior approach, suboccipital midline, the lateral for lateral approach, and we can go the perisigmoid, the retrosigmoid approach, and we can go the endoscopically, or when we are going through the midbrain, we can also go through the superior cerebral infratentorial approach to get some biopsy at that site. These are some approaches we can choose, but we can enter through these entry zones up to me. So this is the brief introduction and some entry zones to the brainstem.
Thank you very much,
Thank
Dr. Etizaz, about this lecture, amazing lecture.